Good morning, good afternoon, and welcome to everyone here for the World Health Professions Alliance webinar about COVID-19 and occupational disease. We have a wonderful panel of speakers today to speak to you on this subject. But before we get going there, I'd like to just run through a few housekeeping matters. You will all be on mute and your camera will be off for the purposes of this meeting. We ask that you put any questions that you may have in the Q&A function that you will see at the bottom of your screen by pressing the Q&A button. You can also upvote any questions that you really think are important to be answered, so we can prioritize those when we're open for questions. And if you do experience any problems during the webinar, please email info@world.physio and our wonderful tech support, Rachel, will be happy to support you. Now, before we kick off with the expert panel, we have a little poll that we'd like to run with you, just to see what your opinion is about the COVID-19 and whether it should indeed be classified and treated as an occupational disease or not. Rachel, could you please launch the poll? Lovely. So please go ahead and answer the poll. Do you think COVID-19 should be classified and treated as an occupational disease? Yes, no, it depends, or I don't know. Just to get a sense of how you're feeling today, what the opinions are. Give another couple of seconds. We've got about half the people online. So online today we have over 30 people, and we will be recording the session for further transmission after the event. Okay, we've got a few more people who are able to vote. Another 5-6 seconds, and then I will show you the results. Okay, I'm going to stop and share the results there. So as you see, almost half of the people on the webinar believe that it should indeed be classified as and treated as an occupational disease. And then there are some, it depends and I don't know. So hopefully by the end of this webinar, you will, we will have teased out the it depends issue. And for those who don't know, maybe you'll be able to then decide whether it should or should not. Oops, sorry. Fabulous. So without further ado, I'd like to hand over to our facilitator for the session, Catherine Duggan, who is the CEO of the International Federation of Pharmacists. Catherine.
Thanks a million, Helen, and welcome everyone. I'm delighted to be here today for this important question of our times, COVID-19 and occupational disease. It's also part of the WHPA Stand Up for Positive Practice Environments campaign, and we look forward to informing you more about that as well. As Helen mentioned, I'm Catherine Duggan, CEO of the International Pharmaceutical Federation, and we are a founding member of the Alliance. The World Health Professions Alliance, WHPA, represents more than 41 million healthcare professionals and brings together global organisations representing the world's dentists, nurses, pharmacists, physical therapists and physicians. WHPA was founded in 1999 with just 3 international professional organisations, and today we have the CEOs of each of the 5 partners of the Alliance: FDI, World Dental Federation; WMA, World Medical Association; ICN, International Council of Nurses; ourselves, FIP, World Physiotherapy. Welcome all. So in the COVID-19 pandemic, health professionals and other healthcare workers have been and continue to be at the front line of our outbreak response. And as such, they have been and continue to be exposed to different hazards that put them at risk. Race, ethnicity, underlying health conditions, occupation type, and job setting can also contribute to health professionals' risks of acquiring COVID-19, experiencing severe outcomes, and sometimes even death. Occupational hazards include exposure to SARS-CoV-2 and other pathogens, violence, harassment, stigma, discrimination, not to mention heavy workload and prolonged use of personal protective equipment. And we've seen many visual pieces of evidence to show the impact of these. Now, colleagues, we simply don't know the exact number of health professionals who have been infected, who have died, or have been otherwise affected by the pandemic. However, we do know it's in the tens of thousands. Given we're in the middle of the World Health Assembly this week, we know it's an issue of note and one the Director General of WHO is taking very seriously in the year of the Health Worker 2021. But today, WHPA has brought together a range of experts in occupational diseases to better understand what it means to classify COVID-19 as such, and how we can all contribute to moving this critical issue forward so that our frontline workers are properly supported. I'm going to now move to introduce our three panelists. My first panelist is Dr. Raymond Aegis, Emeritus Professor of Occupational and Environmental Medicine. He was, until he retired in 2019, Director of the Centre for Occupational and Environmental Health at the University of Manchester Faculty of Medicine. Dr. Aegis is the Deputy Chairman of the Occupational Medicine Committee of the British Medical Association and is a member of the UK's Industrial Injuries Advisory Council. His research interests have included the tracking and monitoring of new and emerging occupational diseases. Welcome, Dr. Aegis. Dr. Shengli Niu was trained in medicine and specialised in public health, epidemiology and occupational health. Dr. Niu worked for the Ministry of Health of the People's Republic of China and the World Health Organization in Beijing before he joined the ILO in 1994. He's currently working as a coordinator and senior specialist in occupational health in the programme on safety and health at work and the environment, also known as Safe Work. Dr. Niu has led a number of international efforts in developing global policies on occupational safety and health, including the updated version of the ILO's International List of Occupational Diseases and development of international guidance on workers' health surveillance and on national systems for recording and reporting of occupational diseases. He's currently leading an international expert group to develop ILO's international guidance on diagnostic criteria for occupational diseases. Welcome, Dr. Niu. Last but by no means least, we have Professor Dr. Lord Guderis, who is a professor at the Centre of Environment and Health at the University of Leuven. He is CEO at the IDEWE, a Belgian external service for prevention and protection at work. He investigates the impact of work on health by unravelling the underlying mechanism, and also the reverse, how health can affect work disability. Professor Guderis is a member of the expert group that advises the Belgian government on the measures and exit strategy in the COVID-19 crisis. Welcome, Professor Guderis. So for the next 20 minutes or so, I'm going to walk you through a moderated session. I've got some questions that I will ask, and I'll move around our speakers to make sure that everyone can contribute. But if any one of our speakers wishes to add to another one of the questions, simply just put your hand up and ask, no problem. I'm going to move immediately to Raymond. What constitutes an occupational disease? Raymond, I think you're on mute. It's our famous 2020, 2021 words.
Yes.
Welcome.
Hello, hi. Well, I mean, there are several definitions, but the simplest one is a disease which is primarily caused by occupation. But in the context of COVID, as well as in the context of other occupational diseases, but especially things like COVID, which are a disease with a very high prevalence in the community, it poses a big problem. It's not like asbestos-related disease like mesothelioma, which is very specific. And in the context of trying to define it as an occupational disease, I think people need to be aware that there are various purposes for the definition. You want to define it as an occupational disease so you can measure the burden of it, how many cases there are. You don't need to define it as such. If you do good epidemiology, you can get by without calling it an occupational disease, just knowing what jobs people did. Are you defining it as such so that people can get on and investigate it, in which case you need a quick, simple, easy definition, which is just functional? Or are you defining it as such for compensation purposes? And if you are, there are various ways in which you could do it. You define certain aspects of the disease, all cases of disease, or just deaths and long COVID, or those on respirators, or those who had to take time off. And in terms of the occupations, do you just name certain select occupations and say you automatically get it? Or do you say, if you fulfill those two, you then need to have an individual assessment? Or do you have a hybrid between those two, which will take care of many cases, but still allows for specialist assessment of individuals? So the answer is very difficult and complicated, I'm afraid. Thank you.
I think it is indeed, and I think that's probably why our poll at the beginning wasn't unanimous in any way. I'm going to move to Shane Lee now and ask, what are the arguments for and against classifying and treating COVID-19 as an occupational disease? Raymond's shown us how complex this is, but what would you say for and against? Again, you're on mute.
Can you hear me? Okay, thank you. Thank you. When people talk about occupational disease, talk about definition, and they may have different perceptions, different understandings about the meaning of the name, about the meaning of the definition, because the definition is often linked to the application, to the purpose of the definition. That is why people ask for and against, and they have different understandings. Let me start to see, if you define a disease is occupationally, is caused by occupational exposure, and that implies many things, not only the compensation of the victims, but also actions to be taken at the workplace. That is why if you go to the national legislations, often you will find a legal definition of occupational disease. And that is different from, in many people's mind, work-related disease. So occupational disease really is often or most commonly seen in the national legislation. And in the ILO actually has a number of legal instruments on occupational diseases. And ILO actually has a legal definition on what is an occupational disease. So normally it is considered a disease contracted as a result of an exposure to risk factors arising from work activities. And why the definition is done in this way, actually it emphasizes several elements. The first one, the exposure is occurred, or the exposure occurs in the course of the work. Secondly, the exposure is linked to the performance of work activities. And thirdly, it is sometimes related to risks which are uniquely existing at the workplace. But this may not be always the case. If you go to many countries, they also classify some diseases which do not have a clear, existence at the workplace. But because it happens during the course of the work, then it is recognized. So if you see the definition, essentially, it emphasizes two parts. One is that you must have a scientific evidence to support the causality between the exposure and the disease, or it is recognized based on national conditions and practices. So these are the practices in the whole world. So when people ask, when people they discuss for or against, they are often thinking from different perspectives. Now, talking about the COVID-19 here, really, if people are thinking healthcare workers, if they are infected with COVID-19 during the performance of their work, obviously, that is fully in line with the definition in many of the countries and in line with the ILO definition. But why in some cases it is not so clearly recognized is because COVID-19 does not only exist at the workplace, does not exist in the setting of work. It also exists in our common life in the community. So that is why there's a need to make a distinction and to verify how the exposure occurred and how the disease can be linked to the exposure at the workplace. So this is the dilemma between the argument for and against.
Understood. Thanks so much, Shengli. I'll come back to you in a short while. So we're understanding, colleagues, that because it's not limited to the health workers' environments, then it may not necessarily be limited to being just defined as an occupational disease. But may I go to Lord now and ask you what happens or would or could happen when COVID-19 is classified, if it were classified as an occupational disease? What would you think would happen?
Well, I think first for the individual, I think if your disease, COVID-19, is recognized as an occupational disease, in many countries, your medical costs will be reimbursed, compensated. And also the damage, your health damage will to some extent be compensated as well. And even if you die from it, in many countries like Belgium, also the family members will be reimbursed for the death that has been caused by COVID-19 infection that has occurred at the workplace. So to some extent, it compensates for a loss in function, loss in health, or even a loss in life. So to some extent, it's used as in many countries. This is done by the Funds of Occupational Diseases, which are institutes that are specialized in making these assessments, and employers contribute in different ways to this institutes, and like that they avoid to some extent as well that they need to pay additionally for the damage they might have caused or work might have caused due to occupational risk factors. So that's on individual level, yeah, a clear advantage, so to speak, so to say, on why it's important to declare your disease as an occupational disease. But as a preventive working doctor, the physician working in prevention, I think declaring any kind of disease that could be related to work is quite important for the better prevention of it. And I think that's very important also in COVID-19 times. And I give the example here of healthcare workers are, I think, evident, right? We are treating people infected with COVID-19, so it's obvious that the risk there professionally is quite high. But we've also run an analysis in which we have studied the incidence of COVID-19 and in different sectors. And there, for example, we observed that meat processing and producing plants, and specifically the poultry processing and preserving industry, that there the incidents were higher. And I think at that moment, if you observe these things, it's very important to better understand, to go and investigate why this is. There are different factors that can explain this. But it will help us, these figures help us really then in order to improve the prevention and taking measures. And also for healthcare workers, that has helped us a lot in the beginning, because the efficiency of the protective measures that were taken and implemented, remember also which type of mask that needed to be worn and in which circumstances. Well, due to the fact that people declare their disease to Funds of Occupational Diseases, helped us to get the right numbers and to improve these measures. So it's both interesting for prevention purposes and for compensation purposes.
Thank you so much, Lord. I'll come back to you towards the end, and I'm going to Well, I think it is. It's very, very complex, isn't it? And it's not just about the classification and compensation. It's about prevention. Really, no one should be suffering with this terrible disease. Can I ask both Raymond and Shengli, please, to comment on how you think health professionals advocate for and raise their voices for this to happen in their country? What would be your advice to the health professionals? And then I have a question for you, Lord.
Well, thank you. I think advocacy is important, and it's essential that people do so, but it has to start on the basis of evidence and not just on emotion. So different countries have got different mechanisms for reporting disease. Those have to be taken full advantage of. If those mechanisms for reporting disease are inadequate, then that has to be called out and criticized and improved. The points that have been made, which I and other speakers made about prevention, have to be put first and foremost. You can't just say this is about compensation and about money and expect to get the same response as if you step back and say that this is about prevention too. I think participation in any project which generates information by way of research is important. Once you then have that background, then you're in a better position to advocate. But I'm not an expert on advocacy myself, so I should leave that to other people. Thank you.
Brilliant, Raymond. So Shengli, what is your reflection on how health professionals can advocate for and raise their voices?
The health professionals normally they are best equipped in terms of knowledge, in terms of experiences. Their role as how do I see advocates to raise the awareness of the society, to put the argument on the agenda of the government, and to promote the prevention and protection of the workplace. The healthcare professionals, they have a unique role here. At the same time, they also have a unique role to protect themselves, because they are the ones who are needed most when a pandemic like this happens. So therefore, they have a unique role, not only for the protection of others, but for the protection of the healthcare workers themselves.
Mm-hmm. It's like a double responsibility, really, isn't it? It's yeah, it's quite profound. So finally, back to you, Lord. You know, I've described what WHPA is, who we represent, 41 million health professionals across the fields of dentistry, medicine, pharmacy, physical therapy, and nursing. And I just wonder, what do you think we should do? We've got our positive practice campaign, but how should we support our health professions and raise awareness to gain traction?
I think your group potentially, I think, can play a big role in raising the voices of the members you represent, because that's why you have this consortium, right? So you want to gather together, to think, to have this debate. I think it's very important as well, and also to see, to talk to your members, have their opinions, and represent your members at different boards and places. So I think, yeah, you might have a very important representative role for your members. But on the other hand, I think you also can help in spreading information, in disseminating the information and getting insights. And as you are working with different professions, you probably also could play an important role in sharing good practices among each other. So really also stimulate this, and especially because, and I will give the example of nurses. Yeah, there's quite some, we have seen quite some differences in the availability of preventive protective equipment between nurses, depending on whether you're an employee or self-employed. Yeah, the information you dispose of might be very different already, but also, yeah, the kind of PPE you dispose of might be different as well. And there also the knowledge might be quite crucial. So in that sense, the fact that you probably cover both of them, I think it's a big opportunity also there to spread the information and practices. And also in things of, yeah, you've talked about the vulnerabilities, but I also dare to say that within the healthcare sector, despite knowledge might be higher and health literacy might be higher, that I still think that there are quite some vulnerable groups, people, migrant workers, temporary workers, that probably do not have the same rights and access to adequate protection. And I think also there, I think as an organization, you can help to overcome the inequalities that have been introduced or caused by, or augmented even due to this pandemic and the measures that have been taken.
Thank you so much, Lord. I know we will be writing those down and taking it as a call to action to ourselves, not only to our own individual professions, but as the Alliance. Thanks a million to all three of you. Now I'm going to hand over to Howard Catton, CEO of ICN, and our 2021 Chair of the WHPA Chief Executives. Thanks a million, colleagues.
Catherine, thank you very much, and good morning, good afternoon, everyone, and thank you to our panelists as well for your thoughts so far. If I may, I'm gonna just want to follow up on some of the issues that you've raised, and in a gentle way, perhaps if I could push you a little further. We as the World Health Professions Alliance have been extremely concerned about the lack of good data on infections and deaths amongst healthcare workers generally. Just a few days ago, Dr. Tedros in his opening remarks to the WHA actually said that they now believe that the number of health worker deaths globally as a result of COVID was at least 115,000. That equates to about 200 deaths a day. And I don't wish to be dramatic, but the equivalent of a 737 passenger airliner going down on a daily basis. We've done some work at ICN trying to look at infection rates amongst nurses, and it's varied over time, but we found where we have been able to get data, 6 to 8% of infections amongst healthcare workers. If there are 168 million, there have been cases globally so far. If only 2% were healthcare workers, that's about 3 million. If it's more than that, well, who knows? It could be up to 10 million. So we seem to have a real problem with capturing data, and you've talked very articulately about the importance of the data to lead us to issues around prevention. How do we get better data? Is it through recognizing COVID as an occupational disease, or, and I think Dr. Aegis, you said that there are other ways that we could get better data as well. So firstly, do you agree that there's a problem that we don't have good enough data? And if you think the data could be better, how do we go about getting that? Dr. Aegis, can I come to you first?
Yes, thank you very much, Howard. Yeah, you don't actually have to call it an occupational disease to get good data. In fact, some epidemiologists will tell you, you don't want to call it an occupational disease to get good data. We won't go into the details of that statement, but it does have some validity. In other words, if you collect enough data of good quality on all the people in a population contracting the disease, if you have correspondingly linked to that enough data of good quality relating to the jobs they did, you can then calculate metrics like the population attributable fraction, where you can say, on the basis of knowing from this data what jobs people did and knowing who got the disease, we reckon that so many people, we cannot name them, or such a proportion of the people actually got COVID as a result of their work. And good epidemiology will show us that, and I think the figure quoted by you, or Tedros said, might turn out to be right. I don't think it'll be too small, if any, too big. I think if anything, the true figure might be even higher. So that's what epidemiology does. If, on the other hand, you needed definitions for compensation purposes, then as I illustrated and other speakers illustrated, then you have to have something which goes down to an individual level and which will tell you beyond reasonable doubt that that person got the disease. That's why I started by saying my comments in respect of advocacy were on utilizing the mechanisms that already exist and strengthening those in countries where data is being collected but could be better collected, to underline the point that you've just made. We need better data, so any arguments are based on hard evidence and not just our own emotions, valid though they are, as to what is right and what is wrong. Thank you.
Thanks very much. Professor Godoris, I saw you reacting to some of those comments. What's your view on the how do we get better data?
Yeah, I think we need to. I will tell you the story of Belgium because as was kindly introduced in my introduction as a speaker, I'm giving advice to the Belgian government. So I have a quite direct line with the Minister of Public Health and Prime Minister. And I have to say that that was a game changer for me as a researcher as well. That made it possible that I could investigate the incidences and relate them to the workplaces. Before, I was not allowed to do that, which is actually quite extreme, because on one hand, we have public health institutes that gather the information, data on the PCR positivity, because that's the data then we disposed of. But it was basically impossible to link them with the data, with databases that contained information about workplace and the sector where people were working. So that was really a difficulty, despite this information was available. And one of the reasons for that is that the initial focus was in the beginning not on what we have talked about. How can we prevent the spread of the virus through work? The focus was how can we diagnose in an early stage and treat people as good as we can. The typical paradigm of the healthcare sector. Let's diagnose and treat was the focus. And then on public health, there was much to do about staying home, closing all different kind of sectors, but actually without knowing exactly which were the key sectors that were responsible, so to speak, so to say, for or were most at risk for spreading the virus. And I always find it very strange that that policymakers did not urge public health agency to make this data available for doing this type of analysis. And eventually I managed, but it cost me more than 8 months to get 2 databases linked together. So it was quite complex. And moreover, I tried to do it now also on European level, but that's very difficult because every public health is as such not a authority of on European level, and it's very difficult to do this on European level. So I think we really need to make data more easily available, especially in this kind of pandemic situation, which causes a lot of death, not only due to the virus, so you want to understand better how it spreads, but also due to the consequences of an economy you close down, and also the potential consequences for health of many people as well. So I think it's really, we need to talk to our policymakers on how we can get access to the data to really do to make these analyses, which are quite crucial.
There was a fascinating response and example of your work. Can I? So what you've described there was in terms of flying blind with data that was very generic. But when you were able to get more granular data about workplaces and where particular risks were to then better protect and better prevent. Are you able to say more as to, because for advocacy purposes, actually being able to show those outcomes of, look, you did this work and we were able to better protect people in these sectors, or we were to prevent people in particular jobs, and the impact on the economy more generally may have been X, Y, Z. Feels like really important sort of outcome evidence. Is there where should we look for that for advocacy purposes, and how could we use that? Could we use that more?
No, what we've doing, so now we have the evolution of the incidence of COVID-19 over different sectors. So that's quite interesting, and we can plot then these data according to the measures that have been taken. At a certain period, maybe also in your country, hairdressers were closed. Of course, at that moment, it's normal that hairdressers say, "But yeah, why are we closed? Because we are not the cause. If you do not have data, how can you defend a measure target a specific sector if you do not dispose of the data?" Well, actually, with the data we have now, we really could show why this was necessary, and also the consequences of the impact of these measures on the incidence globally, but specifically also in this working population. And I think it's extremely important not only to underpin, so to support by data the measures you are taking, explaining it to people, which also increases the acceptability and the compliance and the adherence to these measures, and also avoid that other sectors are closed in which maybe the risk is much lower, and that it does not contribute so much to the global pandemic. And I want to give another example here, is because if you look within healthcare workers, and that's again our data showed that, for example, dentists for us had significantly lower incidences compared with other healthcare workers, which seems a bit surprising at first, because if you look at the kind of job they perform, they're very close to the mouth of the patient they treat. They generate aerosols. So better, if you look at it from a risk assessment at the workplace, let's say, you cannot imagine a higher risk. Despite this, I think the fact that dentists are very well trained and prepared to work under these conditions, they are well informed, well protected, made that the incidence could relatively remain low. Also, patients were quite well instructed. And so that gives really important cues on how to implement better protocols for specific professions and improve it. And I think that's quite important. And like that, you find a balance between your public health outcomes, results you want to obtain, but also take into account that that people need to work for living as well, and that's quite a difficult balance that we had to deal with within this crisis, I think.
Fascinating examples, and from a nursing perspective, we also picked up what we thought initially were almost counterintuitive in terms of necessarily not a higher risk in intensive care units, but actually in care homes or home care nursing, where the greatest degree of risk is. Dr. New, I'm going to come to you, because I think that we've heard a hugely powerful and persuasive case to have better data, but that policymakers or politicians, one or the other or both, are not requiring the data to be made available as powerfully perhaps they could. From where you sit, from an international organisation, from ILO, would you agree with that? Do you think that there hasn't been enough done to make the data available? And if you think that more could be done, any speculation or view on why politicians, policymakers may not have been stronger in their steer to make data available?
Thank you. I think, Howard, when you start your introduction, you mentioned about the statement by the DG of WHO concerning the regrettable situation of healthcare workers. One sentence one word he used is scanty. I mean, the report is scant. This is what he used. What he said, why it is like this? I mean, generally speaking, people consider COVID-19 as a public health issue, but in the workplace, it's really an occupational issue, occupational health issue. And here the data is even more scant. Why things like this? It's like a chicken egg. If it is not recognized as occupational disease, obviously no one is willing to report that. And the national recording notification system does not cover this. So clearly there's a strong need of data, but we cannot wait until the data is available. So how do I say, most countries, they have to act. They have to act without sometimes without appropriate support of data. This is one of the issues from the ILO perspective. It is very important is that, you need to have a platform to hear the voices of different stakeholders. Here, for example, like healthcare professionals, the association you represent, I mean the WHPA, because from the ILO perspective, the employer has an obligation to ensure the safety and health at the workplace. That means even if you have one case, that is already an indication that the workplace is not safe and healthy. So you cannot always to see, I need to have a certain amount of fatalities or cases of diseases, then it is an issue. So that is why to see, if we have appropriate forum to debate, on the one hand, based on the data available, on the other hand, based on consideration from other perspectives, so that a mature policy can be formulated and can be applied. So to make myself clearer, data is just one part of the story. And on many situations like this, we cannot wait. Obviously, we have to emphasize the importance of data, but at the same time, we have to think other ways, other approach to address the crisis.
Thanks very much, Dr. Nu. We're joined by my chief executive colleagues from World Physiotherapy, from the World Medical Association as well. So I want to come to Jonathan and to Otmar next. In terms of what you've heard from our experts so far, perhaps firstly a view or a response in terms of what's resonated most with you in terms of what they've said and what you have been hearing, the issues or the concerns from the groups that you represent. Jonathan, shall I come to you first?
Sure, thank you, Howard. And it's been a really interesting discussion and lots of different thoughts going on in my head. I guess I always sort of come back to an advocacy sort of position. So this could be a theoretical discussion, or it could be actually something that leads to some advocacy activities that actually then leads to benefits for my constituents, which are physiotherapists out there in the community. And I guess I'd probably like to twist it a bit and ask a question of the panel as to whether or not they think there is a comparable disease or condition which we could look at in terms of, you know, its impact on particularly the healthcare industry is one part of it, and see the trajectory of that as an issue that then became an occupational disease that was then able to be dealt with. So I guess I'd be curious if anything resonates or anything comes to mind about a comparable disease or condition.
Jonathan,
or is it the great, or are we just all in this, you know, we're reinventing and we're making it up as we go along?
I'll thank you for that, Jonathan, and I will come back to our panelists in just a moment so they can think about their response to that question. But Otmar, to come to you just before that, in terms of your reflections on what you've heard so far and what resonates with the medical community.
Yeah, thank you very much, Howard, and thank you to the speakers for very interesting contributions there, most of which I absolutely share. Yet I have some additional comments which I would like to share with you, and maybe some of this also raises into questions there. I do understand, and Professor Aegis, you mentioned this quite clearly. There have to be a number of rules to follow in order to really sort in something as an occupational disease, and then also look for the question of compensation. And what is in the background, to me, what I understand is the matter of fairness also to the community, not to be compensated for something that can happen to everybody. And as you said, there is really the big question here in a disease that has such a high incidence in general population. There is a remaining question which has to be answered: is there really a case for looking to the health workers there? In communication theory, there's probably the question to separate signal from noise, and in order to see what is really something that is connected to the workplace, caused by the workplace, related to the workplace. And I think that what you said, Dr. Neo, is we have no time to wait for the last definite answer in mathematics there and in numbers, but we have to look for the context. And as far as I understand, very often we do so in acknowledging, especially in healthcare, a needle stick injury with an infection, if there has been a needle stick before. Not necessarily 100% knowing that it comes from that you acquired hepatitis C or something like that. We connect, in my country, for instance, in Germany, we connect an accident that happens to you on your way back home or to work as a workplace-related accident, and regardless how stupid it was at this point. So there is something which I understand also can be bound to the context, although I share, of course, the idea, having a background in research, that it would be very nice to have really the data and to look for better answers in the future. Now, my additional comment I would like to make is, aside from these effects of protection of the individual, of the health professional or the health worker, and the preventive effect that Professor Goderich mentioned, I think there is another effect which is utterly important by the occupational protection, and that is the preparedness to engage. What we have seen very often, or at least several times in epidemics, is that health professionals, physicians, for instance, would lose their preparedness to engage with patients. There are historical examples, like the physicians in the plague in London and the role of apothecaries at that time, where the physicians would not treat the patients, but the apothecaries would do that for the physicians, for instance, because they wouldn't like to go there. We have the example of physicians which were reluctant to treat HIV patients in the beginning of the epidemic, when HIV was a deadly disease. And there was a reluctance to do so by some people. Now, luckily, our colleagues, the health professionals, have been really enormously courageous in dealing with the COVID-19 disease, and we have really very rare incidences that people said, no, we don't want to do that, and we don't want to engage. But I think the question of protection is also therefore very important to have a workforce that is willing to engage, because they know that somebody cares for them in case they themselves are being affected by that. And that is something which I think should not be forgotten in this whole discussion about occupational disease and compensation. This protection, I think, is also something that is very strong. And maybe you can give me your opinion on that, whether that is a reason for having this under consideration. Thank you. Back to you, Howard.
Otmar, thank you very much. I'm going to come back to all three of our experts now, and I think there are probably three issues in there, which if you want to have a go at all of them or at one of them. Jonathan's in terms of whether there is another comparable disease that we could look at and what the learning from that would be. I'd just expand that a little bit as well, and also a comparable sector. I mentioned, you know, what the reaction would be if this had happened in the airline industry. What would happen if it happened in police forces? 200 deaths on a daily basis for over a year. And then this point from Otmar in terms of preparedness to engage, and to add to that and to put it a slightly different way, that you know, we turn on our TV screens and some people might think, well, actually a healthcare professional role at the moment is one of the most fantastic jobs that I could possibly do, where I can, you know, make a huge difference to people and be inspired. Or they could think exactly the opposite and think this is the most dangerous jobs in the world, and you know, we're going to run into even more severe problems in terms of recruitment and retention as well. So any of those areas, Dr. Aegis, to you first, please.
Yes, thank you. I shall be brave and try to tackle all those points, but briefly, because you have to allow other people to speak. On Jonathan's question, analogies, in recent memory, living memory, there hasn't been anything of the scale. But if you go back to the historical records, we've had the Spanish flu virus, which took a huge toll of people, nurses and doctors and so on. We have had in recent times, this century, the beta coronaviruses, SARS-CoV, the first one, MERS, and so on, where precautions were followed, like respirators and so on, which unfortunately were not used as universally for this SARS. And we have the experience of these diseases like measles, chickenpox, and tuberculosis, which are recognized to be airborne, even though they're very difficult to culture. And yet for this SARS-CoV-2, there's been a lot of unfortunate reluctance to accept that it is airborne, which I believe it is. Next one, I'll move on quickly. Otmar, first point, definition and criteria, especially for compensation purposes. I think it might require a dual approach, namely those occupations where the relative risk is quite high, maybe nurses and so on, more than doubling of risk. Then you can say, right, let us assume that for those people in those jobs where the risk is very high, if they fulfill the disease criterion, if they fulfill the job criterion, they qualify, and then allow a second route, the accident route, which would then take more time because it has to be looked at on an individual basis, which might permit compensation of others. On the refusal to engage, I am not aware of circumstances in which that arose. It might have arisen, but I don't know. I know of circumstances in which it was the opposite, where healthcare workers have not refused to engage, even though they felt that they were not adequately protected, sadly. And some of them died, sadly, and they have documented that they said they were not protected and they died, sadly. But there is another refusal to engage, which we mustn't forget about. I'm done and I'm supervising research on this, and that is burnout, which leads to the depersonalization, where we can get health workers at the end of this who are burnt out. And COVID or not, they will lose that empathy, that capacity to engage with people temporarily or permanently, we don't know, but that will be quite a big headache. I'll stop here. Thank you.
Dr. Aegis, thank you very much. I'll come to Dr. Nu next. We've only got about 4 minutes to go, so a couple of minutes, Dr. Nu, and then we'll go to Professor Godoris. Dr. Nu, you first.
Thank you. You know, I think again in the speech of the director of WHO in the WHO's annual conference, it says, you know, healthcare workers, they are doing heroic work, but they are not superheroes. That means they are human beings like, anybody. They can be diseased, they can die. So here I want to emphasize another aspect is the right issue. The workers, like all the other people, they have the right to work in the safe and healthy working conditions. So that means they need to be properly protected with adequate protection measures. And people will recall when Ebola happened a few years ago, the doctors in some African countries, they were on strike because there was no protection at all. So here, if we see the statistics, clearly healthcare workers, they are at a very high risk of getting infected and die. So if we see worldwide, we have like 59 million healthcare workers. How many of them? 115,000. That was a very conservative estimate. If you calculate mortality rate, and in comparison with the general public, at least 4 times higher. So that really indicates how do I see the appropriate protection need to be done, and the right issue need to be emphasized.
Thank you, Dr. Nu. And finally, back to you, Professor Godoris.
Yeah, I think other infectious diseases have occurred. I'm also thinking, for example, of hepatitis B, tuberculosis are other examples. The difficulty often is indeed the proof of causation, which is often required to be recognized as an occupational disease, and it's very difficult for many infectious diseases that you got in contact with the infection, with the virus at the workplace. I think for hepatitis B, in terms of needle injury, it's different, of course. But for tuberculosis, yeah, there you had the same problem. And I think also in COVID-19, we cannot do source tracing. We do not dispose of techniques that tells us where we got infected or not. So that's really a lack in research and knowledge we have. And in terms of preparedness to engage and also fairness, I agree, Otmar. I think it's we need to be fair in our compensation. And also would like to add simply there is that we also need to be fair in the right on good working conditions and availability to the protective equipment. So I think I see fairness as something over all aspects of work. That's what I wanted to add to this comment. Thank you.
Professor Godoris, thank you so much, and thank you to all three of you for your insights, your expertise, your time, and I think what has been clear through this discussion. Clearly, there are a number of challenging issues of detail, but when the data is available and when we are able to analyze and interrogate that, our improved understanding can but only take us to a place where we can better protect those working in our health systems and prevent infection and death as well. WHPA are going to continue to take this issue forward as part of our advocacy on behalf of the 41 million plus health professionals that we represent. We have a campaign called the Positive Practice Environments campaign. On our website, you will see and can find many more details about that campaign, how we create positive practice environments. There are fact sheets, there are briefings, there are posters as well, and I think, as we all know, that's not only an issue of doing what's right for health workers. Health professional rights are human rights, but when we do the right thing by the people who work in our health systems, we create safer, more effective, higher quality healthcare systems as well. So do watch out for more that will be coming from WHPA WHPA. The recording from this event we will make available, and there will be a summary as well of the key issues that have been raised. Thank you everyone for your time today, and thank you once again to all of our panelists, to Dr. Aegis, Dr. New, Professor Godoris, and of course Jonathan and Otmar as well. Thank you and goodbye.
Thank you. Bye-bye.
Ciao.